إن شاء الله موجود الأسبوع القادم بإذن الله.
Right, Samer?
Yes, I can see it very well, yes.
Okay, great. Let's wait for the guys to check in. Where it go? This one.
By the way, Samer, there is something with the voice with your laptop. Your voice was very loud, and I did notice this in the... Brilliant.
Okay, I think we can start. Let me see who has with us here from my team. Ahmed. Ahmed, you want to start? Ahmed,
Yeah.
okay.
Yeah,
Let me start recording. Just 1 second.
Recording in progress.
Okay, Ahmed, let's go and start.
All right. A 78-year-old woman who presents with one episode of right hemispheric TIA 2 weeks ago is found to have ipsilateral carotid stenosis of 80% by CT angiography. She has severe pulmonary hypertension and an anatomically high carotid bifurcation. She is scheduled for transcarotid artery revascularization, TCAR. On morning of the procedure, the anesthesiologist notes that the patient forgot to fill her prescription for clopidogrel preoperatively and has never taken clopidogrel. The most appropriate management is...
Okay, before we start, so this patient, she go for TCAR for stenting. We know for stenting, patient has to be in dual antiplatelet at least for 6 months, right?
2 weeks.
It depends what study you look, but usually we keep it for 6 months. But the question is that she forgot to take her, dual antiplatelet. Yeah, I think the same question have it in CSAB 5, same questions. So let's go one by one and see why it's wrong, Okay.
Okay. A, postpone the operation and begin dual antiplatelets with a plan to proceed within 1 week. This is very reasonable.
Okay. What is any risk of free waiting because she's symptomatic?
Yeah, she has the risk of to develop a stroke with this waiting. However, the risk of having stents inserted without preloading is higher.
Okay. Is the risk of stroke high or low?
The risk of stroke not having the procedure is high, but not having the preoperative management is higher.
What I'm saying is that you're going to wait for a week, right? So in the waiting period, in 1 week, is the risk of stroke is high or low? And roughly how much is the risk of stroke?
What I know is that the risk of stroke within a week of not having the procedure, within 7 days, 2%.
Yeah, so it's about 2-3%, something low. So it's not very high. So we can wait. It's not a big deal. It's more risky than to go without antiplatelets,
Yeah.
Why we don't just, what usually we do, or even the cardiologists they do, they just load her with Plavix. Why we cannot do that here? Because they do that in coronary. Sorry?
The pharmacokinetics of clopidogrel. It does not work through this way.
Oh, it takes like at least a day or two to work, So we don't like that. But they do it in the coronary because coronary is different from brain. Brain is very sensitive. Coronary, but I see people in coronary they do that. They load patients with clopidogrel. You know how much they load them? What's the loading dose they use?
300.
300, yes. They use 300 and aspirin. And they proceed with the stenting. Any place, even the renal, lower extremity, if the patient not taken, we can't do that. But the brain is different, it's very sensitive, so it's better to respond it. I agree with that. All right, so let's go to next answer.
Administer 650 milligrams aspirin suppository and proceed with the procedure. The issue is with Plavix, not with aspirin.
Correct. And we don't give suppository anyway.
Yeah.
Right, okay.
Then perform transfemoral carotid stent with distal embolic protection. The same idea with TCAR and transfemoral stenting. The patient has to be preloaded.
Okay, so the problem is the stent, is not the way you proceed. Correct. Yeah, okay.
Load the patient with 150 of clopidogrel and proceed as planned. It does not work through this. And even the loading dose of Plavix is not 150.
Okay.
E. Convert the case to carotid arterectomy and vaginal anesthesia. The patient has pulmonary hypertension and high risk. So the idea to proceed with stent because of the high risk. So you cannot just ignore it and go for arterectomy.
Correct. But don't forget, if you do it for low risk patient now, because the indication for TCAR is for high risk patient, but nowadays they start doing even for low risk patient. So if you do it for low risk patient, I think this option would be a good option. Just forget about it and go do carotid endarterectomy. But when you do it for high risk patient, then you don't do it. Like this one has severe hypertension, you know. But if they never mention severe hypertension, you cannot presume they are doing for high risk patient, then this answer could be correct. Okay. So you have to be careful in the exam how they present the question for you. Omar, you want to add something to this?
No,
question?
I totally agree with your comment. When I have something, I will raise my hand.
Okay.
Yes. Brilliant.
Great. Okay, brilliant. Cool. Okay, who is was Yahya? Yahya with us. Let's go to the next question.
Hello, Dr. Samer, okay?
Yeah, hello.
57 years old man with history of hypertension, hyperlipidemia, present with right hemispheric transient ischemic attack and emboli in the right hand. CT angiography demonstrate a severe atherosclerotic lesion of the innominate artery. This is lesion extending from the origin where there is a dense calcified plaque to the mid-distal portion of the artery. The remainder of the ascending aorta and aortic arch are relatively non-calcified. The right subclavian and carotid artery are patent without hemodynamic significant disease. The left internal carotid artery has a 70% stenosis. The most durable surgical reconstruction of this region would involve.
Okay, before you start. So what we have here, we have a focal lesion or stenosis in the innominate artery, correct?
Yes.
And this cause is symptomatic. It causes both TIAs and emboli to the right hand, correct?
Yes.
Also, we have left internal carotid stenosis, okay?
Yes.
What is the best treatment for these lesions, you think? Forget about the answers. What does the guideline tell you really with this lesion? What's the best treatment for this lesion? Really is the best treatment. Go ahead.
Right innominate, diseased.
No, I'm saying how we treat it. This patient came with innominate artery stenosis and severe stenosis and his symptomatics. The guideline they put as the first line of treatment really is stenting. But you do retrograde stenting, not antigrade, because the risk of embolize. So really the guidelines tell us to go like what they do TCAR. Suppose the common carotid artery, you go retrograde and you stent. And then you flush the common carotid artery so you don't embolize to the brain. This is the best treatment, But here, the question they said, what is the most surgical? So they want to go with the surgery, They didn't say what the best treatment for this lesion. Because I think, and maybe Omar can correct me, I think the guidelines said the best treatment for innominate artery stenosis is stenting, not surgical. Because it's easy, but you have to be done retrograde, not antigrade, because you cannot put a filter. Because if you want to put a filter, you already cross the lesion, you can emboli. So the only way is to go retrograde. From you make small incisions in the neck, you go to common carotid artery, you clamp it, and then you go retrograde, you stent, you flush it, and then you open. So called retrograde stenting of the innominate artery. But here they want you to do surgical. Okay. Before we proceed, Amar, you want to add something for innominate artery stenosis or occlusion?
Here's a question here. He didn't ask for the best treatment for the patient, but he said the best surgical reconstruction. So he concentrates on surgery and he want to know your surgical skills in such a lesion, how to tackle it. Do you do total aortic arch replacement to this patient with all its risk, or do you do limited bypass? So he want to see the candidate, how he perform surgical maneuver to minimize the risk of this patient. But I totally agree. If this patient, I will do endovascular, as you exactly said. And the option here is start to measure how invasive he need to be to get the best treatment.
That's true. Okay, so let's go to the surgery now. So you decide to go with surgery, okay? Maybe because young guy, I mean, you can argue because he's young guy, 57, maybe surgical could be a good options. So what the best options, you know? Remember, he had an limit, but he had also left internal carotid stenosis about 70%, which is asymptomatic. So let's start one by one and see why it's right or wrong. Let's start with the first one.
A, left to right carotid bypass. The
Okay.
left carotid is diseased, and
Correct.
this innominate artery disease showering will not
Correct.
correct answer. B,
Correct. So,
sternal.
but no, before you go. Again, we need to learn, right? I mean, it's the whole idea from this
Okay.
meeting, not to answer questions, you know. So left carotid to bypass, I think this could be a good option. If you do what? Some people, they go there to the left because left 30%, even asymptomatic, some people consider it is way to treatment. So they do left endarterectomy on the left side. And instead of doing a patch, they use this arteriotomy as anastomosis with the graft, and they do left to right carotid bypass. So you do endarterectomy, instead of putting a patch, you put a bypass graft from the left common internal carotid artery all the way to the right common carotid artery. So this could be a good option, but you have to do endarterectomy on the left side. And then the lesion has to have symptomatic only on the carotid, not carotid and arm, because this one has carotid and arm. So this way you address only the carotid, you don't address the arm. Because if you do this one and you ligate the proximal right internal common carotid artery, you still have a risk of embolization to the arm. So in this scenario, this is not your best option. Okay?
Okay.
Well, I'll go to the next one.
B, sternotomy and innominate artery endarterectomy.
Endarterectomy. So it's
Yeah,
like localized endarterectomy. You see,
but
go ahead.
sternotomy, it's good option.
Good options.
But yeah,
Okay.
but I will see another.
So, okay, let's go. I will come back to this one. Okay, let's go to the next one.
Left to right carotid bypass and right carotid subclavian bypass.
Okay. So he did two bypasses. Okay.
Yeah.
Well, let's go. Go ahead.
D, total aortic arch replacement.
Okay.
It's major surgery.
Okay. And
A, sternotomy and ascending aorta to distal innominate artery bypass.
bypass. Okay. Do like a bypass to the distal innominate artery. Well, let's go one by one. Yeah. Okay. Let's go to B. Sternotomy and innominate artery endarterectomy. As you said, it's nice. Okay, but think about it as technically. How you can do endarterectomy? You have to clamp the aorta, correct?
Yes.
The origin here, the lesion at the origin of the innominate artery. So you cannot put a partial clamp here because the plaque at the origin is not distal. So how can you put a clamp? You can to clamp the whole ascending aorta. You cannot do that because no outflow, correct? So you cannot put a complete clamp on the ascending aorta. And you cannot put a partial clamp at the innominate artery because the plaque at the origin, you cannot clean it. So this one is not good when you have a lesion at the origin. This is good when you have like mid or distal innominate artery, you can do that. Then you can put a Statinsky clamp at the origin, and then you can open and do endarterectomy. But when the lesion at the origin, then you have to clean the aorta, the arch, then there's no place for partial clamping. So this will not work. Okay. Let's go to the next one. Left to right, left to right and bypass a right carotid subclavian. This is a good option. And you ligate the right common and subclavian. But the problem, he has internal carotid artery stenosis. So this one does not address it. If he didn't talk about internal carotid stenosis, if the internal carotid artery is clean, this would be a good option. An easy option, I think maybe it's even the best option. But because he has left internal carotid stenosis, and this option does not address it, then it's not a good option. But if he said that we'll do left internal carotid endarterectomy plus left to right carotid and right carotid subclavian, then I think this would be a good option. Okay? Well, let's go to D. D is total arch, aortic arch replacement. You don't need to do that because he told you the rest of the arch is normal, right? So why need to do total arch replacement and deep hypothermia and all this risk? So I don't think they're good options. The last one left is E, which sternotomy and ascending aorta to distal innominate artery bypass. Yes, this is what usually we do. You open the sternotomy, you put like the same when you do debranching. You put a partial clamp on the ascending aorta, and you do bypass to the innominate artery or common or bifurcate to common or subclavian. It depends how the lesion. But the whole idea to do a deep branch from the ascending to the innominate or to the common carotid and subclavian. So this will be your best option. Is that clear?
Clear, Dr. Samer.
Samer, can I ask question?
Yes, please.
Yeah, regarding the option B, sternotomy and innominate artery endarterectomy, because here in the question, if you do sternotomy and ascending aorta to distal innominate artery bypass, the region is still there and still it can shower to the brain. Is it?
No.
We did not solve the whole problem because the region is there.
No, you have to ligate there. You have to ligate distal to the clamps. Then they do a bypass. The reason why I told you you're going to do a bypass to the innominate artery distal or to the common and subclavian. Depend how space you have, you know, how big is the lesion. But you have to ligate it, of course, because otherwise you keep showering, you know. And the second thing, if you don't ligate the ascending aorta, you know, you may get you can get showering. So you have to ligate the innominate artery. You have to ligate the innominate artery. And then either you cut it completely and you suture the stump and then you do end-to-end anastomosis. This is the best option, really. To cut the innominate artery distally, suture the stump, and do end-to-end anastomosis between your ascending aorta and innominate artery. If the blood going all the way very high to bifurcation of the innominate artery, then you just do a bypass to the right common carotid artery, and then another bypass to the right subclavian artery, and then you ligate the innominate artery, or both origin of the right subclavian and right common carotid. But you have to ligate this after the lesion.
Okay, thank you.
Okay. Ali, I saw Dr. Ali Nahas was us. I'm sure Ali has received a couple of these lesions. You want to add anything, Ali?
Hi, Samer. Good evening.
Hi, Ali.
Yes, we see these lesions.
How you do them instead? Do muscular surgery or you do stenting? Or
Stenting, retrograde stenting.
Retrograde stenting. Yeah, I think it's the easiest way.
You hear me?
Yeah, I can hear you. Yeah, go ahead, please.
Yeah. Usually we go by stenting these lesions, as you said before, Samer. But the question is about surgery. I think it is inverted aorta or ascending aorta to the left and the right carotid artery is the best option, I think.
Yeah. All right. Well, let's go to the next question. Osama, you want to take this question, Osama?
Yes, Dr. Samer.
Okay. Let's go to
Okay. Patient present with asymptomatic high-grade instant restenosis of carotid artery stent noted on duplex ultrasound. The statement the most accurately reflects the optimal next step in management of this lesion. So they talk about the restenosis of the stent.
Okay. This is a very common question. And we have some guideline in that. Maybe Omar can correct me.
Yeah.
So you have instant high-grade stenosis.
Yeah.
What the treatment? So You have to distinguish between asymptomatic and symptomatics, you know.
Yes.
Do you know how we treat them? Do you have an idea?
I think, no, I'm not sure about the answer.
Okay. If patient is asymptomatic, okay, then it's a controversial here. If symptomatic, nobody argue about it. You have to fix it, you know. And you have to fix it, you have different ways. You have stenting, reballooning, surgical. We can talk about it. But asymptomatic, this is the question. Should we do it or not, you know?
Yeah.
And the problem, we don't have a strong trials, you know, to tell us what to do. The reason why you need an NDT meeting and maybe neurology and like discussing about this case and you decide. All depends how bad is the lesion. Is the patient symptomatic or not? How is the contralateral artery? Is a severe stenosis and occlusion or is wide patent, you know? So how is the patient condition? How is the long-term survival of the patient? Is he like, you know, old patient or a young patient? So I think you have to look at all this one and make a decision. So it's not like straightforward decision. So I think with asymptomatic is much easier. So
Yes.
let's go on through them and one by one
Okay.
see what they said. Okay.
And confirmation of stenosis with CT is needed before treatment. Now he's looking for any possible indications for doing re-intervention for this stenosis. So you see the other options. Redo carotid stent is superior to endarterectomy. As far as I know, the restenting is superior for doing endarterectomy in case of carotid stent.
Okay.
C, analyzed stroke risk is greater than do you know about risk atherosclerotic stenosis?
Mhm.
Not sure.
Okay. Nice.
Contralateral occlusion does not influence management.
Okay.
No, in case of contralateral occlusion, if you have stenosis, you need to treat it. So even if it is asymptomatic. E, drug-coated angioplasty is superior to redo carotid stenosis.
Okay.
Stent.
Okay.
I think if I will answer E. Drug-coated
Angioplasty is better than redo stenting. Okay. Well, let's go one by one first. It's confirmation stenosis with CT scan. Okay. He said he has a high-grade stenosis, right? With a duplex.
Yes.
You know the duplex is what? Is operator dependent.
Operator
right?
dependent, yes.
So you cannot blame anything on duplex ultrasound, unless if you are in special hospital, you trust your own, you know, vascular lab, and you did at least 20 study of vascular lab duplex compared with a CT scan, and then you can say, okay, I can, because I see some people they put their decision according to the duplex ultrasound, but this is only in the institute where you have a vascular lab, and you already you examine or you test your vascular lab with 20 cases of duplex ultrasound compared with a CT angiogram. Then you said, okay, I can't do that. But in general, you cannot depend on duplex ultrasound to do any intervention if you decided. And the second thing, high grade, it depends. He didn't give you velocity because high grade for somebody, maybe it's low grade for me, right? So really, I think you need to confirm with CT scan. If you decide to treat it. If you not said treat it, you don't need to do that. But if you decide to treat it, don't treat it depend on the duplex ultrasound. You need to confirm with the CT. Okay? So this one looks reasonable to me. Well, let's the next one. Redo stenting is superior to endarterectomy. All the studies showed that redo stent, endarterectomy, angioplasty, restenting, all of them the same. It doesn't matter. It depends what you think is better or which one better in your hand. But all studies show there's no difference if you have instant stenosis between endarterectomy or redo stenting or drug-coated balloon or normal balloon or drug-coated stent. All this different things you can think about it all show the same result. So you can pick up which is the one best in your hand. So this is not correct. Okay?
Yes.
The stroke rate is greater than de novo. No, it's the opposite because stenosis in the internal carotid artery is not an atherosclerotic disease. It's an fibrosis. So usually the stenosis is very nice and smooth. It's not irregular and ulcerated even atherosclerotic. So the chance of embolization is much less.
Yeah.
So really the stroke rate and even redo surgery or with in-stent stenosis is not high like de novo atherosclerotic disease. All de novo usually is the worst. Okay. So this should be wrong. Catheter occlusion does not influence management. No, it influences, as I said, when you have to decide to treat it, you have to look at the other side. You have to look at the age of the patient, where is the lesion, the life expectancy of the patient. So I think this is one important. This is wrong. And last one is drug-coated angioplasty superior to redo stent. No, all is all the same, so it doesn't make any difference. Okay?
Okay.
So this is for in-stent stenosis. I'm sure Omar and Ali, they want to add something. Go ahead, Omar, please.
Yeah, I agree totally with what you said. The in-stent stenosis is different disease from the carotid stenosis, the initial one, because the initial carotid lesion usually embolize, but in-stent stenosis due to myointimal hyperplasia is very benign condition, and there is a lot of diversity, but most society agree on asymptomatic, even high grade stenosis managed conservative, because this is not an embolic lesion. It just can cause hypoperfusion if the other side, contralateral side, is not working properly. So, for example, the A question is the best answer because we don't have a definition by duplex what is high and high grade stenosis in any stent. We know that high grade stenosis in normal carotid, any peak systolic velocity plus more than 250. But in stent stenosis definition of the peak systolic velocity, some papers say it is 450 centimeter per second, others say 600, others say 800. So even inside the duplex community, we don't have a unified, but you will see a lot of duplex reports say high grade in-stent stenosis. So the first step to make your decision properly is to go for CT scan. While carotid lesion, people can do carotid endarterectomy just based on duplex. That's right. But if you have in-stent stenosis, no question about it, we do CT scan first because the stenosis inside the stent is so much variable. It is not easy to put a stent inside. Drug-eluting technology did not show any benefit, and that is why this is a very tricky question. But the answer is A, as you exactly said. Absolutely right.
Yeah, very good. I mean, you mentioned something I forgot, which is very good. Yeah, you cannot use a criteria for carotid stenosis, same on in-stent stenosis. I agree 100%. It's different criteria.
Exactly.
And this is what the problem with the duplex ultrasound. They depend on the ICA stenosis criteria. This is why they say high-grade stenosis, which could not be on CT scan. Yeah, you're right.
Exactly, because the hemodynamic, once you put a stent in the internal carotid, the hemodynamically totally changed. So we don't know what is the peak systolic velocities that tell you that this is high-grade in-stent stenosis. Definitely no atherectomy devices could be used. Definitely no drug-eluting technology showed any benefit in the carotid or the renal, which is the only two territory that it didn't work. So the best thing before you decide treatment is to confirm by imaging investigation. And here we go to the golden standard, which is to do CT before any management. I totally agree. I'm not sure Dr. Nahas will do the same.
I agree with you, Dr. Samer. These three stenosis are really very, very low number, about 8%, if I remember well, are symptomatic, not more. But in this case, I will answer A. But in my daily routine, I will do the SA to confirm this stenosis, if it is present or not. I believe that the DSA, the digital subtraction angiography, is more accurate to define the degree of stenosis in these cases. In these cases, I will opt for DSA. But for the answer, I will answer. For the question, I will answer A.
Great. So Omar, let me ask you, Omar, so how would you use asymptomatic high-grade stenosis, in-stent stenosis? Do you treat it? You don't treat it? Do you go
No,
with a
I
specific
always-
number? I mean, you did a CT scan.
Yes.
What the number you go and fix it? And
I
the second
always-
thing, do you
yes.
use a protection
Asymptomatic.
device?
Asymptomatic,
Yes.
I don't offer them anything other than best medical treatment, which is antiplatelet, double antiplatelet, and follow up, and maybe a little bit of anticoagulation, triple antiplatelet therapy if his bleeding risk is low. I always manage him conservative. I haven't seen a high grade stenosis which has caused symptom, the one that I have followed up. I have seen high grade stenosis went into occlusion, but the process went to completely asymptomatic. I can see Dr. Ahmed raised his hand.
Yeah. But before we go him,
Yeah.
even like 90% stenosis, you don't fix it?
No, I don't fix it. 90% stenosis I still manage conservative because we do the carotid treatment due to embolization, not due to hypoperfusion state. Unless the contralateral side is occluded, and this asymptomatic 90%, which in that case will be symptomatic if it causes dizziness or vertigo or whatever, but always instant stenosis, I always manage in conservative. There are some indication in few centers with big series of carotid intervention, and the figure they think about it is 90% plus plaque morphology, which means that it's irregular plaque, friable, GSM score on duplex to be very high, which means have a bit of embolization. But instant stenosis usually myointimal hyperplasia. It's fibrous, it's tight. Sometimes people do dilatation to this lesion under protection or without protection, but they are very tough lesion to treat, and they can rupture balloon. But my limited experience, I always follow them conservative with reassurance. In my practice, I haven't seen a problem, but this doesn't mean that this is the world experience. But I'm very conservative.
But it's like, okay. Just for the exam, guy, if you get this at exam, a guideline said it's a controversial. So asymptomatic high-grade instant stenosis, you have to do an MDT, discuss with the neurologist, and come on decision. That's why I didn't give you any question, any answer like that here, because it's controversial.
Yeah.
But if you get in the exam, the answer is that you have to do an MDT meeting, and then you decide depending on a lot of factors.
Absolutely.
Stenosis, atherocyte patient. So you need to consult the neurology and decide what the best answer. Symptomatic is different, but asymptomatic, you have to do MDT. Yeah. Ahmed, you have a question?
Yeah.
Go ahead.
Dr. Muhammad, he said something about the best medical treatment and adding dual antiplatelets, Abex and aspirin. I didn't recall any evidence to suggest that dual would outperform an aspirin alone with a statin. Instead, actually, we have studies just doubling the statin would decrease the risk of stroke, but adding dual would not make any difference according to faster trial.
But to answer, Omar?
Yes, that's a very good question. Yeah, very good question, because the best medical treatment have it changed over the last, let us say, 5 to 10 years. They went from double antiplatelet therapy into single antiplatelet with statin. And it seems that statin is the only drug which can cause regression of the carotid plaque. I am still of the old fashion of aspirin, clopidogrel to give to the carotid lesion, but I am sure that the new guideline would recommend a single aspirin and a statin as a standard, but again, it's not unified all over center. I know in UK up till now, we still for carotid lesion, one of the best medical treatment is double antiplatelet. There was an era where they went into triple antiplatelet, but the incidence of bleeding and the stroke was much higher. So this went down very quickly. I'm not sure what Samer and what my dear colleague from Syria will do to these patients. But I know recently they rely on single antiplatelet plus statin. I'm not sure what Nahas do and what Samer do.
I agree with that. And what Ahmed, you're talking about, yes, antiplatelet doesn't show dual antiplatelet is better than single plus statin, but this is an ICS stenosis, not in instant stenosis. Instant stenosis, we don't know. That is why everyone goes with his own experience, really.
Yeah.
So this is a bit different. They said instant stenosis, not ICS stenosis.
Yeah.
So we don't know. I mean, yes, but the study, if you talk about study, yes, I agree with you. The study showed there's no benefit for dual antiplatelets and single antiplatelet plus statin, yes.
I always go with statin. I think that statins are the cardinal points in this treatment, but I still use dual therapy, dual antiplatelet.
Yeah.
But the statins are the cardinal point in our strategy in these cases.
And again, why I'm saying
we have to raise up the dose of the statins for these patients.
right. Maybe here is different, Ahmed. Maybe I agree with Omar that dual antiplatelet is enough because here we don't have a plaque. We don't need to stabilize the plaque. It's a fibrosis.
Yeah.
So the main problem of fibrosis is hemodynamic, disturbance and embolization. I mean, not embolization, disturbance which can form a clot.
Yeah.
So in this condition, it's not like you have a plaque, you stabilize. You have fibrosis called stenosis. Maybe dual antiplatelets will work better in this condition than aspirin and statin, but I don't know. But
that is true.
My feeling.
I've opened sometimes a few of my carotid stent, and when you see a stent causing stenosis, and sometimes we do vein patch and we do excision, and it is so fibrous, totally different from the carotid plaque lesion. It's like another different disease. And as you said, it's very fibrous, it's sticky, it's not friable, and it is not full of lipid core like what you see with the carotid. It is filled up with fibrin and with smooth muscle cells. It is really tough. But I will go and look around to see what is the best medical treatment for in-stent stenosis. But I think, as you said, Samer, there is no guideline in this because there are very few cases with very few follow-up. But it's a very good point.
The second thing is that when you do any stent, like redo carotid, when you open, we don't do endarterectomy because there's no plaque. It's fibrosis. We just go do a patch.
Yeah.
So when you have a redo carotid endarterectomy, when you go there, you open the common carotid artery external, and you don't do endarterectomy because, again, it's just fibrosis. You just put a patch and you dilate it. You make it bigger, Yeah. If you have any stent stenosis, I didn't have to go there and do any of them, but I think if I have to go with them, most of them end taking the whole stent and put double shin vein graft because I don't think there's a place for endarterectomy in this kind of lesions. So either you put a patch or with a stent, I think you take it out and put a double shin vein graft. Will be my, my feeling, but I'm not sure. All right. Yeah. Let's go next to the next questions. 2011. Who else now? Osama Abdullah, right? Abdullah.
Yes,
so you want to take this question? Yes, take this question.
A 63-year-old man is referred to the clinic after carotid bruit was discovered by his primary care physician at his annual checkup. The patient is an active person who exercises regularly. He denies any neurological symptoms or vision change. A carotid artery duplex was performed with binding as shown in the figure. He was already started on daily aspirin by his primary care physician. What is the most appropriate? Okay. Appropriate next step. Yeah. Most appropriate next in the management.
Okay. So he's asymptomatic, correct?
Yes.
Okay. And how much the velocity in the ultrasound? Duplex ultrasound?
It roughly is 562.
Okay.
It
so
is
what
written
that mean?
After. Yeah.
Where is it? Okay. What does that mean?
Severe. Yeah.
Okay. So we're dealing with severe asymptomatic carotid stenosis. Okay?
Yes.
forget what everyone does it. I'm sure everyone does it different. Everyone has different opinion. But let's say what the guideline said. Let's say about the American guideline, what they said for asymptomatic severe stenosis. Do you do surgery or conservative management?
So if it's asymptomatic, more than 70%, we will go for carotid endarterectomy.
Or stenting. But
Yes.
For everyone?
If the life expectancy of this patient more than 3 years.
And
right,
correct. Stroke rate and mortality should be less than
yes.
Hmm?
Yes.
Yeah. Yes. So stroke mortality should be less than 3%. Okay. And then life expectancy should be more than 3 years. What else? Has to be a young patient, like less than 75, because they found if the patient is old, more than 75, he will die really from something else before he get any symptoms. So patient has to be less than 75 years old. It's an important, okay?
Yes.
And this is what the American, the European is more conservative. They like to have some like criteria. So they call high risk criteria. Okay. Some people they go, this is enough. Some people say, no, that's not enough. I have to have high risk criteria for the plaque. Like on the ultrasound, you see like, illucent plaque, you see hemorrhage behind the plaque on MRI, or he has like contralateral stenosis or occlusions, what else criteria? So they look at the special criteria to decide to treat it. They don't look only at the stenosis, okay? So it depends which guideline you look at them. But if you are liberal, this is enough. Second thing is that it should not done by junior consultant. Asymptomatic should be done only for somebody who did at least 50 to 60, even some people they said 100 carotid before you do asymptomatic. Because stroke and stroke and death should be less than 3%. If stroke rate is more and death more than 3%, you lose this benefit. So you should not start as a fellow or junior consultant. You should not start doing asymptomatic carotid stenosis. You should do only symptomatic. Because before you know what your stroke rate, you cannot do asymptomatic carotid stenosis. This is very important. Okay? So in the oral exam, if you got asymptomatics in oral exam, I think you answer that I am, just starting. I prefer not to do it. Or you refer to the high center with the high volume of carotid lesions. In the written exam is different. You answer what the guideline. You don't talk about your own experience. The guideline said, yes, you do it if you have 1, 2, 3, 4. Okay? Yes. Let's see the answer and then we'll talk to the other consultant here. Let's go one by one. So the patient already on aspirin. So he's already on aspirin and he's asymptomatic, correct? Okay. Yes. So let's see what we're going to do.
Add the high dose statin therapy. Okay. We can. B, add a high dose statin therapy and ultrasound surveillance of right carotid artery stenosis at 6 months interval. No.
Why not? Why not?
Because he is severe stenosis. He needs treatment.
Okay.
C, dual antiplatelet therapy and add a high dose statin therapy. Single versus dual. Still, yeah.
Different.
Yeah.
Okay.
Discontinue the daily aspirin regimen and plan for urgent right carotid endarterectomy. It is not urgent.
And you don't have to stop an aspirin.
Yes. Add a high dose statin therapy and plan for elective right carotid endarterectomy. I will go with E.
Yeah. I mean, it's an easy answer, but again, we have to talk about asymptomatic. So this is a plan for asymptomatic. It's a controversial, but I think, let me hear what Omar and Ali want to say about asymptomatic carotid stenosis, when they do it, and how they do it.
Yeah.
Omar?
Yes, asymptomatic above 70%, I definitely do them. But as you said, this comes late in your career. And in United Kingdom, we all get our stroke rate. This is by national registry. Once you cross 2.5, your stroke rate, a committee will come and analyze what has happened. and they will take from your list the asymptomatic one, because you don't get any benefit if your stroke rate is 3% or above, then patient didn't have any benefit. No question about it. The first stroke is massive. You cannot detect where is the time. He's already have a bruise in the neck, which also did not have any, let us say, significance in the indication, but he has more than 70% stenosis in the carotid. But to do full workup to these patients, I wouldn't jump straight away into endarterectomy. I have to do a diffusion MRI, because some of these patients, although they are asymptomatic, but you might have multiple emboli in the brain, which is subclinical, which only show on a specific neurological examination, like conjunctive power and conjunctive assessment. So diffusion MRI is essential. I always do CT scan to see if there is a tandem lesion or not, because carotid duplex scan alone will tell you good information until before the skull, but you need to see the disease after the skull as well. But anything above 70%, I do them, even if they are asymptomatic. I totally agree. And the answer is
Great,
the correct answer, yeah.
Great. I agree with you. I forgot to mention, you're right. You have to do an MRI because patient, they may have a silent, stroke, and you never know about it. First thing. The second thing is that some people, they argue that, behavior changes, cognitive disorder changes could be a sign of silent stroke,
Yeah.
So you need to get MRI to look an idea, because what do you think the asymptomatic could be asymptomatic, but patient is silent, stroke.
Yes.
The third thing, some people argue that you are getting a stroke while you are sleeping, and
Yes.
like a TIA. When you wake up, then you are fine. But
Yes.
really, when you're asleep, you make it a TIA, you don't know.
Yes.
So it's again asymptomatic, not all of them asymptomatic. So I think the best way, as Omar said, get MRI. And if you're not planning to go, because some people they said, okay, this is enough criteria, I'll do it. But some people who are skeptical said, no, I don't do it. Then at least start looking for other things to be sure this is the right decision. Get an MRI of the brain and look if it's having any silent stroke or not.
Yes. I remember
Ali, how you did? Yeah.
Yeah, I remember one of my paper in United Kingdom. They refused to accept the paper because we done the post-operative neurological assessment as a surgeon, and they refused. They said unless it is done by a neurologist, and they showed me a paper that if the post-operative is done by a neurologist, the incidence of a stroke is 30% higher than if it was done by a doctor, by a surgeon. So this is a very important point that you mentioned, that some of them are asymptomatic, they get a stroke during the night, or maybe the only abnormality is conjunctive power. They tell him to mention number 20 backward to 0. They fail to do this test. And this, he had many stroke. But I'm eager to know what Professor Ali has do in these cases.
No, Omar, Omar. Just remind me before I go to Ali. Remind me, it was a case really now. When we started doing the carotid stent in the state, it was obligated that when I finish the stent, we have to get neurological exam for the patient by neurologist,
Yes.
So I did a stent, and as for us, as a surgeon, just move your hand, moving his hand, moving his leg, he's talking, it's fine. I say, okay, he has no stroke. I send him to the floor,
Yes.
And then an hour, he called me, the neurologist, he said, your patient has a stroke. I said, no way. I just talked to him. It's fine. He said, yeah. But they did a thorough exam.
Yes.
And the only thing, he cannot read a number. That's the only thing. He cannot read numbers.
Yes.
He can do everything, but he can't. So sometimes we don't know. Unless you do a very thorough neurological, as you said, you can patient having a minor stroke and you don't know about it.
Exactly.
Unless if you do a thorough neurological exam. I agree with that.
Yeah. Professor
Okay, Ali?
It's important what you have mentioned about the silent infarction. So the fellows must know about this. Not all these are asymptomatic. Sometimes we have these silent infarction and we have to do the CT or MRI. The second issue is these plaques some of them are high-risk plaques. So we have to define them by MRI or by the echo Doppler. If who does the echo Doppler is very expert in these cases. In these cases, I operate really, I shunt electively, and I do as my way to do the patch, and in a very low number, I do eversions. But I always do open with patch, venous patch. I use venous patch.
Great. Just for the junior guy, for the exam, because I always give you what the real life was the exam. In the exam, cognition disorder does not consider as symptoms. So if they tell you that patient was ICS, and cognition disorder, don't consider as symptomatic. This is asymptomatic. So by guideline, until now, they said you should not do cardiothoracotomy for cognition disorders. Okay. So even though you may consider it, but in the guideline, they said cognition disorder is not a symptoms of, and you have treated as asymptomatic until now. Things could change in the future. Okay.
Yeah. That's true.
All right. Let's go to the next question. Who's next? Barak. Barak, you want to take this question?
Ready.
Yeah, please.
59-year-old woman present to the clinic after one episode of right-sided weakness that spontaneously resolved after a few hours. CT angiography of the neck and head was performed, which showed 80% stenosis of the left internal carotid artery, just past the bifurcation, and 80% stenosis of the cavernous segment of the left internal carotid artery. What is the next best course in the management? So this is a 59-year-old with symptomatic left internal carotid artery stenosis and tandem lesion in the cavernous segment.
Okay. I think we talked about it first when we start carotid, lessons or review.
Yes.
We talk about tandem lesions,
Yes.
So do you remember what the
Yeah,
guideline
we
says?
start if the patient is fit for carotid endarterectomy, we start with carotid endarterectomy, and we lift the tandem lesion without intervention.
Even high-grade stenosis?
Even high-grade stenosis, you start with the internal carotid first.
What about the intracranial segment? Do you do ballonic, stenting, or leave it alone, or medical management?
As per guideline, we start only with the internal carotid artery.
Yeah, but I'm saying, okay, forget about internal carotid. Let's say you only have a severe stenosis of the intracranial ICS stenosis. Do you think what the best treatment? Surgery? No, surgery. Stenting, balloon angioplasty, or conservative management, like 90% stenosis?
I think medical management.
Yes. I mean, this is what the guideline. A lot of may disagree, and this is what happened last time. Other people disagree with that. But this is what the guidelines. It came from large trials. They found that severe ICS, intracranial ICS stenosis, they found that if you do balloon stent, the stroke higher than medical management. Last time I talked about a case where he ended with occlusion, but this is what the recommendations. Some people, they may not agree with that, but at least it's not your specialty. At least the worst scenario, at least you said, I will do my left intercarotid stenosis, I fix it, and then I call neurointerventionist to decide, because this is not our specialty, correct?
Yes.
If this option is to be the best option. If you don't have this option, then at least the guideline said best medical treatment. In real life, it may not different, but in the guideline, they said you just conserve management even for severe stenosis, because they have a large trial done by a neurointerventionist. They found that even severe stenosis, best medical management is better than balloon angioplasty and stenting. Okay?
Okay.
So let's go through one by one and see what they say.
A, recommend consultation with neurology interventionist to treat the severe stenosis at the cavernous segment of the left internal carotid artery. It's an option, but it is not the first option. Recommend repeat CT angiography in 3 months.
Sorry. You said not the best option or is not the right answer?
I think we have to treat the internal carotid before the cavernous signs.
Correct. So first you have to read the left internal carotid. Correct. Okay.
B, recommend
And
repeat
we
CT angiography. Yes.
And we don't do them same time both. This is a contraindication.
Yes.
Do them both same time. Okay. Okay.
B, recommend repeat CT angiography in 3 months for close follow-up of the severe concomitant extra and intracranial internal carotid artery stenosis. This patient is symptomatic now. The internal carotid need to be fixed within 2 weeks.
Okay.
C, recommend MRI of the brain and follow up in 6 months. Again, the patient is symptomatic and need to be fixed.
Okay.
D, recommend left carotid artery endarterectomy or carotid artery stenting to treat the left internal carotid artery disease just past the bifurcation. This one may be correct.
Okay.
E, recommend left carotid artery endarterectomy or carotid recommend left carotid artery endarterectomy or carotid artery stenting in conjunction with consulting a neurology interventionist to treat the severe stenosis at the cavernous segment of the left internal carotid at the same time. This one may be an option.
So you have
But I
to
will go
right
with option
answer
D.
D. And why
I
E is
will go
wrong? Why
It
E
is not wrong. It is not wrong, but
wrong?
it can be. But the best option, I think, is D.
No, E is wrong. Why is wrong? Because the last sentence, what they said, the last sentence.
Just past the bifurcation.
No, the last sentence in the E. At the same time.
At the
right?
same time. Yeah, yes.
We don't do at the same time. Yes, you can do them. You can consult them to do them, but don't do them at the same time. They show the risk is high, stroke is higher. So we don't do them at the same time. So if they didn't put at the same time, this could be also a reasonable answer, okay?
Yes.
But at the same time, this is a tricky part of the question, okay?
Okay.
All right. I'm sure Omar has different opinion because he has different opinion last time. So Omar.
No, actually, after we discussed it the last time, I went into the international guidelines, and you are exactly right. You correct the carotid endarterectomy, and even if it is 80% or 90% internal carotid, the guidelines is not to treat them, it's just to manage them conservative. I think because this question is for someone who want to be the first day consultant, so he want to know if you got this lesion, internal carotid, and someone inside the brain, he want to make sure that you will consult a neurologist, that you will not manage this patient on your own, because this will be a fatal mistake. And I have worked a lot with the neurologist, and we have done it on the same time. I do the carotid, and he comes in and do the angioplasty for area of the carotid, which is very high up in middle cerebral artery, even its branches, and we get general anesthesia. We put the patient to sleep. I have done it multiple times. I took the course of intracranial carotid stenting by Horst Siever in Frankfurt in Germany. But they are sometimes when you must answer in your exam what the guidelines say. This maybe is a bit on the cutting edge of neurologist. You can angioplasty this lesion, but this is don't answer this. You are right, Samer. You should answer. Just manage, do multidisciplinary before decision making, and the rest do the carotid and leave the intracranial for the neurologist to follow up and do whatever he like, but it's not indicated. So the guideline said exactly what you say.
Great, thank you. Ali, how you deal with them? The same things or you do differently?
I think the same. I agree with you. I will do my endarterectomy and I will leave the contamination.
Great. All right. I don't see any question from the audience. Guys, if you have any questions, just raise your hand as Ahmed did before. All right, let's keep going. I think we're going good today. 13. Let's go back again to Ahmed. We go back to you, Ahmed.
All right. A 42-year-old man is referred for evaluation of an incidental finding on computed tomographic angiography that showed right internal carotid artery dissection 4 centimeters above the bifurcation. The lesion does not appear flow limiting. The patient is otherwise fit and exercises regularly. He has never had any neurological symptom. Daily antiplatelet therapy is recommended for the management of asymptomatic carotid artery dissection because... Okay.
Before we go with that, how we treat carotid ICA dissection?
Asymptomatic,
Localized. Yeah.
asymptomatic. Per Cadis trial, just antiplatelet or anticoagulant, no difference.
All right. What if symptomatics?
Symptomatic, you have to treat, but the guidelines that I read, nothing. Even in symptomatic, you can treat it medically still.
Yeah, I think even symptomatic you treat medically. Unless if it's failed, then you may think about stenting. But I think even symptomatic we treat medically, you know. You know what the syndrome where you get localized dissection in the distal ICA after heavy exercise? Because you get patients like that called an eagle syndrome. It's from the long stylet process, stylet process. They said if the long stylet process sometimes with heavy exercise or neck movement can cause dissections. Anyway, it's not a big deal. So anyway, I think symptomatic and asymptomatic ICS dissection attributed medical management. No place for surgery. Stent, I don't know. It's not. I don't think so. It's a place even for stent, but we can talk to neurointerventionist. But I think the first treatment should be medical management. I think stenting should be only for symptomatic who failed medical management. Then you may think about stenting, you know. All right, let's go one by one.
Okay, antiplatelet therapy decreases the production of inflammatory mediators, which decreases the risk of fibrosis, stenosis, and ultimately stroke. Antiplatelets do have inflammatory mediator. They do some effect.
But it's not the way they work, right?
Yeah, but it's not the way.
Antiplatelets. Yeah, it's antiplatelets. They don't work with fibrosis and stenosis and all the things. They work by antiplatelets. So I think this is wrong. Okay.
The antiplatelet therapy has been shown to reduce the risk of stroke compared to anticoagulation per Cadis and treat CAD. No difference in either, not even with warfarin.
Correct.
C, antiplatelet therapy can prevent the progression of the dissection flap, thereby preventing further malperfusion and stroke. They don't do change in the dissection flap conformation at all. Antiplatelet therapy has been shown to have comparable outcomes to anticoagulation therapy in patients with carotid artery dissection. That's correct.
Correct, yeah. Okay.
But let me see. E, carotid artery dissection benefits from antiplatelet therapy and surgical repair. Surgical repair is a bit tricky in dissection patients. I would choose D.
Yeah, you don't do surgical repair. Again, if you have to do something, then you do a stenting, if you have to do something. Yeah. But even with symptomatic, I think we'll do just antiplatelets. So be conservative with dissection as much as you can, you know. We have a patient with dissection and even pseudoaneurysm and symptomatic and treated conservatively, and follow-up showed even the pseudoaneurysm is getting smaller, you know. Even it's very easy to go and put a stent and done with it. There's no indications, you know, and we still treat him with antiplatelets and he's doing fine. Just follow him with serial ultrasound. Omar, do you do different carotid dissection, localized dissection?
Carotid dissection is a nightmare for intervention. So we only intervene in symptomatic if the flap affecting the flow. If the patient severely symptomatic, then we put carotid stent. But it is not easy. I remember a car accident. The driver was wearing the belt, but because of the accident, his neck moved forward dramatically fast, and it caused carotid dissection. It did not cause carotid rupture or complete transection, but it's just to cause dissection. And I have consulted so many neurologists at that time, and we managed him conservative. So definitely dissection, you don't want to go neither by surgery nor endovascular unless you really have to, because it is so tricky with your wire to go into the main lumen, and how to make position to the flap, and how to make this situation not to progress further forward with the dissection. So very few people have done a few cases like this. The dissections that I have seen, I've managed conservative. From the exam point of view, it's a very nice question. For example, E is totally correct except and the surgical repair. So every part he want to trick you. What is the correct answer? But you're absolutely right. The answer is D. And for the clinical point of view, always be conservative as much as you can with carotid dissection. It is difficult cases.
Yeah, that's true. And this is, unless we also like flow limiting dissection, then maybe it's different story.
Yeah.
But anyway, I mean, the whole idea is that try to be conservative, even in symptomatics. Yeah.
Absolutely.
All right. Any questions?
Absolutely.
Okay. Well, let's go to the next one. Let's keep going quick. This is an easy question. Oh, really good. 14. Who's next? Yahya. We go back to Yahya.
Hello, Dr. Samer.
Yeah.
Which
you
the
want to
following
question?
are the most common morphology classification associated with FMD in carotid artery?
Well, this is a question. Just it's not like a scenario, really. Just a question you have to read about FMDs, you know. So we're not going to spend too much time, you know. FMDs they come like how many times of FMD you have, or how they show up FMD. Usually, what the sign of FMD, fibromuscular dysplasia? Yeah. You know what the sign? How it's shown angiogram?
It's ring sign, bead sign.
Yeah, string of beads, you know. So it's string of beads. This is the sign of FMD, you know. And usually you see it in the carotid. Then you have to look what else in the renal artery, because when you have a renal, you know, you can. And if I'm correct, I think it also fits with a very aneurysm intracranial, but I'm not sure. FMD treatment is just dilatation because not an atheroma. They respond very well to dilatations. If they are symptomatic, of course. If asymptomatic, it's different. But if symptomatic, I think dilatation is the best treatment for them. So you see them as sign of string of beads, but sometimes you can see just a focal lesion. So you have two types, either focal or you see multiple stenosis. Okay. So let's go one by one very quick.
Alternating areas of stenosis and dilatation limited to the common carotid artery, not limited.
And usually not the common. You see string of sign usually is the internal carotid, not the common. Right? I mean, I never see it in the common. Usually I see it in the internal carotid. So this is wrong. Next one.
Alternating areas of stenosis and dilatation at the distal internal carotid artery or focal, non-atherosclerotic, non-inflammatory region anywhere in the carotid artery.
Yeah, I think it's reasonable.
Yes.
Right? Dilatation and stenosis in the internal. Usually mid or distal and focal. Yeah, this next one.
Only focal, non-atherosclerotic, non-inflammatory region of the internal carotid artery, not only focal.
Correct. So wrong. Next one.
Alternating area of stenosis and dilatation at the distal external carotid artery, not limited in the external carotid.
Usually you don't see in the external. I mean, always the internal. I never saw in the external, but I'm not sure. But I never see in the external. All of them are internal. Yeah. Next one.
Focal areas of non-atherosclerotic, non-inflammatory stenosis at the proximal external carotid artery.
Yeah, this is not. It's wrong.
No,
So I think most of the time you see them multiple in the internal artery or just focal. You know, so I think B is the best answer. So I think it's not much about this question. Omar, do you have experience with the FMD?
Yes, I have experience with FMD in renal, which is very common in young girls with hypertension.
Yeah.
And I think this question asking about the pathology, so you must say the beaded appearance of the artery, عامل زي السبحة, and web, sometime you get web, and areas of stenosis and ectasia. This is how you describe it by morphology. And the commonest, from statistically speaking, is internal. Unusual to see it in common or external. So you are absolutely right. I have treated some of the internal one, FMD, and the beauty about them that you don't need to put a stent, because just a balloon angioplasty and cracking the web and dilating the stenosis is sufficient. And they are usually young patient, age 20, 25, maximum 30. And they are in the two areas, renal FMD, internal carotid FMD. And this is common pathology question that we get for FRCS. So it's important to read a lot about FMD.
That's true. And I remember we used to treat them because I am from the Iron Age, you know that. We used to do them surgically, open the common and get a dilator. So before they came with angioplasty,
Gosh.
we used to get a dilator, you know.
Yes, I know.
Yeah, dilate them with dilator. Yeah, I don't know if you did it, but this is
No, I
from old
haven't.
age, you know.
Did you do it to renal or carotid?
No, carotid.
Wow.
But this is very, very
Wow. In the
yeah, this is
States?
an Iron Age. Yeah.
Yes,
long time ago.
because
Maybe just one or two.
yeah, but
Yeah.
because you were working with Hazem al-Safi, you were doing thoraco-abdominal every day, so no problem. You can put dilator in any internal carotid.
There was no balloon angioplasty at that time.
Yes,
No balloon.
yes,
There was
exactly.
no endovascular, all open.
Yeah.
So you have to treat it and just go open the common cardiac dilator,
Exactly,
dilate
and
them,
get a
and that's
dilator.
it.
Yeah,
And close it.
yeah.
Yeah.
Oh, fantastic.
Right. Ali, you want to add something, Ali?
I don't have an experience with internal carotid FMD
But I think,
but
yeah.
I have experience with renal, and I use cutting balloon, not but normal balloons, but cutting balloons for these. There are few cases in young patients, female patients, and I use cutting balloons. But in carotid arteries, I don't have an experience.
Yeah, just something very quickly, because you are very experienced, Dr. Ali Nahas. A cutting balloon, if you do it in the carotid, you are off-label use of a cutting balloon. Cutting balloon.
I said only in renal. I don't have experience in carotid.
Oh, sorry. Okay. So
no, in renal I use cutting balloons.
Yeah, exactly. You can use it, but from the candidate point of view, a cutting balloon is made by Boston Scientific. It is only 2 centimeter in diameter. It has 3 cutting edges, and the only indication which is FDA approved is stenosis in arteriovenous shunt. You can use it outside this area if you are experienced surgeon like Professor Ali Nahas. You can use it in renal. You can use it in very tight lesion, iliac lesion. You can use it in SFA. You can use it in popliteal artery. But you must know that you are off-label use of the cutting balloon, which means if you got renal artery hemorrhage, then you're unprotected. This is a problem. If it goes well, everything goes well. But sometime I use another trick other than cutting balloon. I put a guide wire besides the balloon. I put 2 guide wire, one at 12 o'clock, one at 6 o'clock, and then inflate the balloon. This way I have got the benefit of the small rim of the wire looks like a cutter without actually using cutting balloon. This is one of the tricks that I use, because I don't want them to use cutting balloon in the renal artery unless they are very experienced like Professor Ali Nahas.
Do you use high pressure balloons or normal balloons?
No, I use high pressure balloon. The best one is Atlas balloon, and Atlas balloon can take up to 20 and 30 atmospheric. But for renal, I always worry about renal artery rupture, which happened to me. And I'm the one which done the thoracotomy, and this is the beauty when you do renal intervention and you are the surgeon at the same time. I can see Dr. Ahmed raise his hand.
Okay, right,
Dr.
Ahmed.
I wonder what is the rationale of using cutting balloon in these lesions? Why not any other specialty balloon like chocolate, for example?
That's a very good question
Chocolate
because
is a cutting
chocolate was
balloon.
not there.
No, but chocolate is a cutting balloon, Ahmed.
Yeah,
So
chocolate,
the same
chocolate
he's
is a
talking
cutting
in
balloon.
general.
Yeah.
Yeah, so the same idea. But Omar, I don't know. I mean, so you're saying it's contraindicated to use cutting balloon in the carotid, ICA? I don't know that. It is something.
Some people have used the cutting balloon in the internal
Okay.
carotid artery, especially for carotid
Alright.
web. Carotid web syndrome,
Okay.
if it is symptomatic, you can use cutting balloons. It's been mentioned in a lot of cases, not unusual. But you have to be very, very careful when you're using cutting an internal carotid artery because you create a controlled dissection. So unless you are very, very experienced, you know what you're doing, but it is mentioned to use cutting balloon in the internal carotid artery in case of carotid congenital web. Dr. Ahmed raised his hand.
Just want to mention.
Professor Omar,
Yes.
returning to renal arteries using balloons only, do you have any percentage of recoiling after inflating
Yes,
the balloons or
30%,
no?
and I always tell them that 30% there is recoil, but the recoil mostly becomes asymptomatic. And if it is symptomatic, we do another dilatation, and again, we don't put a stent. I think I have done 2 or 3 renal artery FMD, which have re-stenosed and re-dilated. Yeah, but you are right. I tell them percentage 30% recoil or recur back again.
Oh, I just want to mention one thing. You mentioned that one of the risks is rupture of the renal artery, and I saw it before. Before you panic, try to do prolonged inflation. Just get your balloon back and inflate it for 2-3 minutes.
Yes.
And I see some cases they really feel very nice.
Yes.
So don't get very scared. You know, don't have to convert to open right away. You don't have to put a stent.
That's true.
Just cool down. Be sure you don't lose your wire. Just get your balloon inflated for 3 minutes. And most of the time when you're beta angiogram, it's already sealed because usually perforation is very small. Yeah.
That's true.
In
I know
mid-aortic
Omar have.
syndrome, Professor Omar, in
Tfadl.
mid-aortic syndrome,
Yes.
renal artery stenosis, which are usually ostial
Yes.
or near ostial,
Yes.
do you use normal balloons or cutting balloons, or you go directly to surgery?
No, I do endovascular. I first do CT scan and make sure that it is not absent segment of the aorta. Some people have an absent segment of the aorta and very flimsy, tight, looks like aortic stenosis, but it doesn't have intima media adventitia. If I done a CT scan and there is an intima media adventitia in the stenosis, I always do it endovascular. I haven't done a conversion or surgery so far for mid-aortic syndrome. And my advice is I do it under local anesthesia to the femoral artery. So patient, when he feels the pain, I don't inflate anymore. I start by 3 millimeter, 5/8. If I reach up to 50% of the diameter of the aorta, I leave it. And my safeguard against rupture of the aorta is patient feeling abdominal pain. Once he feel abdominal pain, I don't inflate anymore. Do you do them surgery, Dr. Ali or Samer?
We have a few cases, but usually we deal with them conservatively until they are over 18. So
Okay.
I want surgically after 8 weeks.
Okay. And what do you do, Samer?
We did both really. We did surgery. We did many surgery for it because it's a bit common here in Saudi.
Okay.
Mid-aortic syndrome.
They are common.
But we try to wait until they come puberty,
Yeah.
age. So if they come young, we try to be conservative.
Yeah.
But if the hypertension become uncontrolled, usually it's hypertension is the problem. You never have a problem with lower extremity. The main issue is hypertension.
Yes.
Then we do dilatation, mild dilatation. As you said, you're not your aim to do a complete inflation. Just 50% is
Absolutely.
more than enough.
Absolutely, yes.
And we do that, and we know this recoil, but at least we can buy many years, maybe every couple of years we do the dilatation until they get to the puberty.
Yeah.
And then we go and do, surgical.
Yeah.
And this is easy because thoracoabdominal in young kids is different. It's easy, and just go and put a patch.
Yes.
And many times you need to address the stenosis in the eye. When you do an open,
Yeah.
you have to address the renal artery stenosis because it's a congenital stenosis. So you have to do, as like bypass or something like that.
Yes. Yes. I have some. We used to do renal artery transplant in pediatric hospitals in United Kingdom, and I've seen mid-aortic syndrome being treated at very young age 2 and 3 years of age. And the problem with it, when you do suturing, you must wear a loop, magnification 5, and you must use Prolene on CC needle, interrupted suture. You don't do it continuous because he will grow. And I have seen collaterals coming from subclavian artery to the femoral artery, which is pulsating as big as the aorta. When you work in pediatric vascular units, it's amazing. So it is difficult to anastomose artery in children because they grow up, and if you done a continuous suture, you will create stenosis for later on. Luckily, endovascular management is quite advanced. I don't do mid-aortic syndrome without covered stent, essential standby. But I haven't seen rupture once I learned the trick about the CT scan. I can see Dr. Ahmed raise his hand.
Yeah.
Dr. Muhammad, thank you. Do you use, Dr. Muhammad, did they use patch or a tube graft?
Variable.
No.
Some cases they use tube graft. Some people they use patch. Some people they used initially tube graft, and when they re-intervene, they done patch. So some have both. The exact surgical technique depend on your exploration on the aorta and how the condition looks like and how the wall looks like. If the wall looks good, you can get away with patch. If the wall is bad, you need to anastomose from healthy to healthy, and tube graft is an excellent option. We have used synthetic, and we used great saphenous vein, a paneled graft, which you get the great saphenous vein and you rotate it around a 10 cc syringe, and you anastomose it together, and you make a tube like the aorta in a child, and you anastomose it. But lately we all use, or they all use synthetic, either Dacron or PTFE. Incidence of infection is the same. So this is what has been done. Okay.
Thank you.
I mean, the cases we did, all of them, we did the patch, and the reason that if you put a tube, then later on you can have a problem because of mismatch,
Yeah, absolutely.
The main issue with the tube graft, yeah. Even when we deal with the aortic aneurysm in the children, it's very rare, but we get, I think, 2 or 3 cases.
Yeah.
It comes with large. This one we don't do like normal. We leave part of the posterior wall, and then we put a graft, but we take the posterior wall of the graft and we leave the posterior wall of the aorta. So when the baby will grow up, this will grow up with him,
Yeah.
And always using tactics such as Omar said in children, always use tactics stitches, running sutures.
You remember the case?
But it's a challenge.
Yeah, you remember the case that you have, Samer, which is the precious child, which came after long 10 years of infertility, and he has an aneurysm, and his young age. You remember this case?
Right. Yes.
This was very impressive.
And I still follow up this case. Yeah. I still follow up this case. He's still doing fine,
Excellent. Very good.
Yeah. Good. All right. Let's go to last question because we're like an hour and a half now. Let's go to last question. Let's go. Who's now? Osama, you want to take last question? Okay. Osama? He's not here. Abdullah?
Hello, Doctor.
Want to take
31
this
years.
question?
Yes. 31-year-old active woman present with left arm pain and weakness, dizziness, and malaise. A bruise is heard at base of left side of the neck. On physical examination, she undergoes computerized tomographic angiography, which showed patent carotid artery and severe stenosis at mid portion of the subclavian. What is the most appropriate next step in management?
Okay, before we go to the best management, young patient, woman, she came with weakness, dizziness, malaise, so she's having like a Steele syndrome. Came to the severe mid-portion left subclavian stenosis. What do you think the pathology? Why patient young get a stenosis subclavian artery?
I don't know,
Because they are
Sarah.
young. Yeah, but usually it's not atherosclerosis for sure, right?
Yes,
So it has to be one of the inflammatory disease, right? Like
fine.
giant cell arteritis, Takayasu, all this, So this is what
Yes.
we usually think. So when you find young patient with severe subclavian stenosis, especially not at the origin, so it's not an atheroma, then you have to think with inflammatory disease, or vasculitis. And the most common vasculitis is Takayasu disease, right? So I think in this patient, this is what you in mind, mostly she has a Takayasu, right?
Yes.
They're not asking about how to treat it, I think, right? No, they're asking how to treat it. Okay, let's say one by one. Oh, right, let's go one by one.
Initiation of antiplatelet therapy.
She has where subclavian artery, she has dizziness. I don't know, I'm not asked. I don't know. Let's go next one.
B, check the IgA level.
IgA is not going to help. It's not in vasculitis. What we look for?
We will look for if there is any inflammatory marker.
Right, what marker we look for? An ESR, right?
ESR
usual order.
Yes. Yes.
Yeah, not IgA. So this is wrong. Usually we look for ESR. Right.
Okay. Check the ESR.
Okay.
I think this is the right. D, left subclavian artery stent placement. This is يعني option in treatment. And E, left subclavian artery to common carotid artery transposition. Also, this is an option in young patients.
Okay. So you see a lot of right answers, right? I think all of them is to me is right. So you have to go back to the question, what they ask you already in the question. Then is this, you look at the question. They say, what the most appropriate next step? See, they put next.
Yes,
if they just put the most appropriate management, then all of them is correct for me. If they say most appropriate management. But they put next step. So what do you do next? If patient has vasculitis, even in our floor, what do we do first?
Check the, we consult usually rheumatology for that, but they will order ESR.
Okay, so the first thing you want to know, is he an active vasculitis or not? Because you don't do any intervention when patient active vasculitis, right?
Yes.
So first thing you want to know is, are we dealing, because any vasculitis has two stages. You have an acute and chronic. So when patient comes with the stenosis and you think it's vasculitis, you have to know, is he an active stage or is a chronic stage? If it's a chronic stage, then I start treatment, either subclavian stent or bypass, whatever, okay? But if an active stage, don't do any intervention active stage. Even with the aneurysms, you saw a couple of cases in our ward, do you remember? Patient, even with the came with infraaortic aneurysm, if it's inflamed and ESR is high, we just wait. We give him cortisone, we treat him until all the inflammation markers go down, then we do intervention, okay?
Yes.
So patient come with a suspicion of vasculitis, the first thing you do an ESR, and if his ESR is high, then we go with a cortisone. If his ESR is normal, then I start treating him with either one, okay?
Yes.
So in this case, the most next step is to do an ESR and then try treatment. So initiation of antiplatelets. So the first one, antiplatelet therapy. Yes, if it's a chronic, but if it's acute, no. The wrong is answer wrong because you give cortisone. Check IgA level. I don't know. I'm not, hematology, but usually go with ESR. Left subclavian stent or bypass is correct, but only in the chronic. Okay? So this is how we should approach the vasculitis.
Doctor,
Omar,
if they ask about the procedure itself, it will be endovascular or open in this young patient?
Good questions. Not open. I mean, you mean bypass or you do stenting?
Yes.
I don't think, I mean, first, again, it has to be of inflammation, you know. I don't think the patency is different between both. I think both have a good patency, stenting or bypasses. I think these days, most people, even young patients, subgiven, they go with a stenting as a first step. But if you do bypass, it's not a wrong answer. Because for me, I think both types of treatments have same patency, same complications, same patency rate. I cannot say one is better than the other one. But I'd like to hear from Ali and Omar.
I think, first of all, this is not state syndrome. This is that because it is segment 2, circulating segment 2, so it is not state syndrome. So we have to go to inflammatory diseases. Using the left circulating artery stent replacement in segment 2, I don't know, I don't think it is recommended. It will break. I will not use it absolutely. Left circulating artery to common carotid artery transposition, it is segment 2, so we cannot do transposition because segment 2, not segment 1. So in this case, I will go to number C to check the ESR, but I will not stent segment 2, absolutely. I will not stent it, and I will not do transposition of segment 2 in case of any problem segment 2. I will go to bypass or to, if you want to patch, but I will not make a transposition.
Okay.
Neither.
Omar, what do you think? Omar?
It is a tricky question. He said, what is the most appropriate next step in management? He did not say what is the final step in management. So the wording is very important. So I agree with your answer, Samer. And regarding if you have the examiner telling you, would you do it open or endo? I will say a quick advice to candidate. If the examiner is young age, let us say 40s, then go for endo. If he is white hair like me, and probably he has done more open, so you say open. Or you can let us say, you say according to the experience, the hospital, the surrounding. So try to hold it little bit in middle way and see which way it will go with the examiner. This is what we usually say for FRCS exam. So don't jump quickly, because if you went into endovascular intervention and he was, let us say, one of the old chaps, which has done all these cases open, it will be a difficult situation. This is my advice. But the wording here, what is the most appropriate next step in management? So I agree with Samer.
Okay. Does that mean Ali is old?
Do you stent
No,
segment
no,
2,
I didn't say
subclavian
that.
segment 2 artery?
Naam?
Do you stent segment 2 in the subclavian artery?
Yes, I do segment 2 and segment 1 as well. I've done a lot of segment 1, which I couldn't reach it from
segment 1, we don't have any discussion about segment 1, but segment 2.
And segment 2, yes.
Why you don't stent it, Ali? I just want to know why you don't
I'm
like to
afraid
stent it.
that the stent breaks. I would know. I'm not
No,
sure.
this was the first
No, this is only if you
generation.
have.
Yeah. With the current
No, I mean,
generation
if you have a
of stent.
thoracic outlet.
Yeah. Like thoracic
It
outlet.
is
Yeah.
like an outlet.
Yeah.
It is not outlet, but you don't. Go ahead.
Now the
Yes.
supera stent fracture has not been recorded. So I agree with you, Professor Ali, that stent fracture was an issue in zone 2 due to the curve at the first strip. And this has caused a lot of fracture with a lot of stent in the past. With the new woven nitinol technology of stent, we started to see fractureless stent. The first one in this group is supera stent, and the second one is the venous stent for iliac compression syndrome, like Venovo stent. There was not a single case of fracture in Venovo. It's all due to engineering. Now it is nitinol woven like one thread going through the whole way. It doesn't fracture. And usually, they tested by putting the stent into machine, and the machine will cause stent pulsation, something like 100,000 pulsation, and they found that the stent doesn't fracture anymore. So stent fracture was an issue, but not with the new stent nowadays. And Professor
Right.
Ali Nahat is very young,
For-
by
We
the
don't
way.
have the para here, so I don't have any experience with these stents.
Yeah. Yeah.
But in general, guys, for the junior, don't worry. You will not get a controversial, question. I mean, something like that controversial, you don't get in the exam. Exam should be like straightforward, something very established,
Yeah.
The reason why they said in the left, they said time bullshit. They didn't say bypass because time bullshit completely is out of question. You don't do it because it's a segment 2. The reason why they didn't put a bypass because bypass then become tricky, So for the junior, don't worry. In the exam, always the question be straightforward, not controversial. All right. I think we have enough today. We passed almost like 2 hours. We'll meet next week. Any